21st century coax. New generation phacoemulsification. 1.8 and 2.2 mm MICS microincision cataract surgery. How to go about it. In recent years, there's an increased concern among ophthalmologists about the phacoemulsification incision stability in a standard 2.8 mm incision, and increasing evidence indicates smaller microcoaxial phacoincisions made with 1.8 and 2.2 mm size blades, offering greater ocular stability and more resistance to deformation caused by patients. This video film depicts various analysis, methodology, and factors aiming to optimize this microcoaxial phaco procedure to obtain excellent post-operative patient results. The active and passive microincisions were measured before and after phacoemulsification of cataract and microincision lens implantation procedures. Procedure and methodology. The blades to be used for these surgeries is pre-calibrated accordingly for creating real-time measured clear corneal incisions, with its horizontal width is perfectly marked with two lines of 1.8 and 2 mm on its anterior surface. Similarly, the other blade has a marking of 2.2 and 2.4 mm on its anterior surface. These marking lines facilitates the phacosurgeon to create real-time measured clear corneal trapezoidal incisions for an optimum leak. Group 1 patients were bilaterally operated with temporal clear corneal 1.8 mm microcoaxial phaco procedure adopting the following protocol. Group 2 patients bilaterally underwent 2.2 mm microcoaxial phaco procedure adopting the following protocol. The incision is created in trapezoidal fashion so that the internal lip is 1.8 mm and the size of the external lip and the length of the corneal arcuate tunnel is decided by the surgeon as the blade is carefully advanced in a controlled manner. The incident angulation of the blade tip on the corneal tissue is recommended to be less than 25 degrees in order to create a longer stromal valve of at least 2 mm. Tapered width at the rear end of the blade creates a 1.9 or 2 mm outer incision lip to maneuver the microphaco tip and the infusion silicone sleeve without any kinking. Clear corneal incisions are made and when measured instantly indicate the active incision size. And when the phaco needle tip instrument with its infusion silicone sleeve is maneuvered in the anterior chamber, the effective internal lip size of the incision is altered to a certain extent on either side walls to approximately 0.1 mm. 1.8 mm and 2.2 mm phacosurgical procedures produce excellent chamber stability due to minimal aspiration fluid turnover. This provides an effective workspace by creating a deep anterior chamber. Post-phacoemulsification, this altered size is passive incision size. This stretch factor varies according to the phacosurgeon's maneuverability and also the patient's corneal tissue condition. In contrast, for a 2.2 mm microcoaxial phaco procedure, the vacuum level could be reduced to a certain extent considering the slightly larger bore size of the inner lumen of the needle being used for the procedure. Active and passive incision sizes were measured even after the aspiration of the cortex with the microcoaxial IA needle tips. A mild stretching of 0.1 mm of the internal lip size is observed. At least 2 mm or slightly more chord length of a clear corneal valve architecture will be required to obtain a better and faster sealing wound. Dimensions of microincisional lens cartridges were measured with a captured image in the scanning electron microscope in order to analyze the internal diameter, external diameter, and the measurements pertaining to its tapered tip. Gradual increment across its tapered outer dimension is indicated of different available micro-IOL cartridges in a partially wound-assisted manner. In case of the patient's left eye, without extending the microincisions of 1.8, the corneal arcuate valve acts as an extended cartridge barrel. Due to this maneuver of the distal tip end of the micro cartridge stretches the passive incision size of the internal lip of the 1.8 mm micro incision to 2.05 mm or 2.2 mm. In the case of a 2.2 mm micro phaco incision, due to this maneuver of the distal tip end of the micro cartridge, the passive incision size of the internal lip of the arcuate corneal valve stretches to 2.4 mm or 2.45 mm when implanted in a partially wound-assisted manner. All the right eyes of the two groups were implanted after prior extension of the microphaco incisions from 1.8 to 2 mm and 2.2 to 2.4 mm with the guarded advancement of the calibrated microblade up to the second level marking line. This facilitates easier engagement of the micro IOL cartridge tip with better grip and induces minimal stress to the incision. This procedure of extending is strongly recommended so as to facilitate a comfort zone for the surgeon to position the distal end of the cartridge tip with more grip in the arcuate corneal valve created. When micro-incisions are measured after lens implantation, the overall width was observed to remain at 2.5 mm or even less in both the groups, which is an accepted incision size for not inducing any surgical astigmatism. While adopting this procedure, the tapered cartridge tip should not be advanced too much into the incision. This might stretch the incision and increase the passive incision size, exceeding the required limitation of 2.5 mm and inducing surgical astigmatism. As the arcuate chord length created is 2 mm or even more, the stromal hydration is not performed in all the patients. Analysis using computational fluid dynamics software by applying the Reynolds stress equation for a turbulent 3D modeled mesh of the human eye anterior chamber as an enclosed fluid domain. In case of a 1.8 mm incision, while simulating a streamlined flow pattern for 25 randomly irrigated fluid particles, it is observed at a given time only 2 fluid particles were aspirated because of the phaco tip's smaller inner lumen, and the other remaining particles stayed back, confirming a deeply maintained anterior chamber. Comparable analysis for a 2.2 mm incision with an equivalent simulated model using dimensions of a larger bore-sized infusion sleeve indicated 50 randomly irrigated fluid particles. Out of these, only 3 particles were aspirated, reconfirming a deeply maintained anterior chamber in such micro-incision surgical techniques, revealing the fact of minimal surgical fluid turnover. Comparing the pressure contour imaging analysis of the 2 incisions under consideration reveals that pressure in the anterior chamber is higher for a 1.8 mm incision size as compared to a 2.2 mm incision indicated in the color scale. In post-operatively observed results, in the anterior segment OCT, the distorted wound architecture and partial wound closure post-operatively were indicated in a few left eyes as compared to all the right eyes which were implanted after prior extension. The wound closure was absolutely fine even without stromal hydration on table for the right eyes. In most of the patients, the measured chord length was 2 mm or more, which correlates to the 25 degrees incident angulation of the blade. The pre- and post-operative corneal topographic results indicate no noticeable surgically induced astigmatism. Specular microscopy indicates a very minimal endothelial cell loss. To conclude, a 0.1 mm extension on either side width of the microphaco incisions in both the groups, which leaves the 2 mm or 2.4 mm measured width hypersquare corneal valve. We recommend a 0.2 mm extension of the microphaco incisions for the implantation of microincision intraocular lenses. In the partially wound-assisted procedure, an overall microincisional stretch factor of 0.1 to 0.25 mm in the measured width of the passive incision size.